I will start the recording. I'll start the recording now, and I will allow Bożena Laskiewicz to introduce our today's guest speaker.
Witam wszystkich, dzień dobry, a reszta będzie po angielsku. I particularly would like to welcome our guest speaker, Andrew Molodynski, who's kindly joining us despite an extremely busy schedule. Being a consultant psychiatrist in these COVID times is really challenging, more than ever. So I won't take up any more time, and Andrew, perhaps you'd like to give your presentation. Thank you.
Thank you very much for that kind introduction, and thank you everyone for joining. It's a real honour to be asked to do this. As people can probably tell, I'm very much a sort of a third generation Polish family. And I apologise for not being able to speak Polish, but I know that my grandfather would have been very proud if he knew that I was doing this. So thank you for giving me the opportunity. I'm conscious that, I'm assuming and conscious that we're all different kinds of doctors doing different things during COVID, or that some of us may have retired, so our experiences will be different. So this is a fairly general talk. Please do feel free to stop me if I'm not making sense. Always happy to be corrected or ask questions, and there'll be plenty of time for questions at the end. I'll just try and share my screen.
I made you a host, Andrew, so that should be...
Okay. Is that working?
Yes.
Yes, it is, yes.
Okay, excellent, thank you. So I wanted to talk a little bit about mental health care in the UK and what COVID might mean for mental health care. I mean, we talk a lot about COVID, don't we, for very obvious reasons. And just to reassure you that the next 30 or 40 minutes is not entirely about that, although it does play a significant part. So as Bożena kindly said, I'm a consultant psychiatrist in Oxford and a senior lecturer at the university, and I've been here for about 15 years. And I'm also the mental health lead for the British Medical Association consultants. But this talk is in a sort of personal capacity, I guess. We will talk quite a lot about the activities of the BMA, but you know, not everything that I say is BMA policy. And hopefully what we're going to do is have a very quick whiz over mental health care and some of the problematic aspects of it in the UK at the moment, and a bit about COVID, and then how we can move forwards, particularly towards the end, focusing on frontline staff, so healthcare staff, social care staff, police officers, shop workers, all the people who've had to be out there during the pandemic. So, in terms of context, so mental health care accounts for about a quarter of NHS activity overall through primary and secondary care, and that's probably a conservative estimate. The economic cost of major mental health problems such as depression, psychosis and anxiety is well over £100 billion a year in the UK. And to put that in context, the NHS costs probably about 140 to 150 billion pounds a year. So it's a huge burden. Despite those two figures, spending on mental health care, and again across primary and secondary care, is just 12 or 13% of the NHS budget. And spending on mental health research is an even more problematical 6%. And the last statistic, which I always put up, often surprises people. So there's very robust evidence in this country, and it's been corroborated and it's been found in other countries as well, that people with severe and enduring mental illnesses, particularly things like bipolar affective disorder and psychotic illnesses, have a life expectancy of approaching 20 years less than their peers. And that's after suicide has been accounted for. Public mental health spending is small, all public health spending is small, but public mental health spending is particularly small. And unfortunately, it has shrunk over the last 5 or 6 years. So we have some issues. One issue is that the mental health system is very, very complicated. I'm sure that in your work in primary or secondary care in different specialties, you will have noticed that it's not as simple as just finding your local mental health team for the person, whatever their age is. We now have a plethora of different services, some in the NHS, some in the charity sector, where people can get help. And many of these are very positive things, but what it does lead to is complexity. And when it's difficult for us as professionals to navigate a system and to get it right, you know, after 15 years, I often get referrals knocked back because they've gone to the wrong place. It makes me worry and wonder how families and people who are affected by mental health problems can possibly know where they are in the system or what's happening. So some of the main problems with the mental health services are that they're very fragmented and pathways are very complex. So an individual can easily, with a relatively common condition such as severe depression or a psychotic illness, so conditions that affect 1 in 4 of us for depression at some time in our life, or psychosis, which affects probably about 1 in 20 of us at some point, they could see up to 5 specialists as part of their assessment and treatment journey, as it's called, in a year, which really leads to unacceptable inefficiency in services, but also for the individual, a lot of discontinuity of care. And a very common concern of people is that they keep having to tell their story to different people, which is often a painful story, unfortunately. So there are very significant gaps in provision and access, and there are often very long waits. And particularly I would call it a cancer in the mental health system, is this chronic issue that we simply do not provide enough mental health beds. So people who are in mental health crisis are now routinely transported all across the country at very short notice for the care that they need, which would be completely unacceptable in any other branch of medicine. And we saw the uproar when during, I think it was the second big wave of COVID, people who needed intensive care were transferred between hospitals or between regions, even in very small numbers. But sadly, the same attention and horror is not given to the fact that we do that for people with mental health problems. Now, I know that this is a very negative start, and it is important to say that the vast majority of people who do get through to mental health services or who are seen in primary care get good quality, humane, supportive mental health care. But it's important, I guess, in my role, that we point out where that's not the case. So this gentleman is called David Knight, or was called David Knight, sadly, and his family very kindly agreed to work with us at the British Medical Association 4 years ago now, following his tragic death. So David was a young man with a very severe mental illness, and there were no hospital beds where he was living at that time to take him when he was in an acute crisis. So he was sent to a hospital well over 100 miles away, which it was very difficult for his family to visit. And tragically, there was a miscommunication between that hospital and his care team at home, and there was a gap in what was happening with David, and very tragically, he took his own life during that gap. And the family have worked with us because they want to try and make it that doesn't happen for other people. And we did a lot of investigation with our sort of investigative team, and we found that in 2016 to 17, thousands and thousands of people with severe mental illnesses were being transferred all across the country. So this is just a very small selection, and I know that the actual figures are quite small, but the arrows really tell you all you need to know. So we have, you know, people being sent up to 300 miles, sometimes more. And the crucial thing to remember is that this is thousands of people, and it's not people with rare and uncommon conditions. So one could say that if, you know, an individual had a particularly rare form of psychosis or a particularly rare form of brain injury with highly challenging behavior and physical health problems, that it would be reasonable for their local hospital not to be able to accommodate them if they had highly specialized needs. And we accept that in all of physical healthcare and mental health care. But what we can't stress enough is that these are just people like you and I, regular people who happen to become very unwell with common mental illnesses, and they're routinely having to be shipped all over the country. So when we aired this controversy with the help of David's family, there was a lot of publicity, and Jeremy Hunt, who was then the health secretary before Matt Hancock, who's been very much in the news this weekend, undertook that within 5 years this practice would cease because it was unacceptable and changes would be made to eradicate it, which was obviously enormously welcome. And to be fair, the Department of Health and NHS England have been working extremely hard to try and do so. Unfortunately, there hasn't really been any significant shift, and we know that the numbers are still in the thousands and haven't really reduced significantly over that 5 years. COVID has been a problem, to be fair to NHS England, because people working in any healthcare environment will know that social distancing has reduced the ability of wards to accommodate people. So many psychiatric wards have had to reduce the number of people that they can accommodate. But the issue was a problem before COVID and will be a problem after COVID. The other thing that has become clear as a major concern is people waiting for therapy. And I know that several people on the call work in primary care, and a common frustration that I hear from our local general practitioners and patients, obviously, and that I feel myself, is that while people can be assessed for their risk and for starting treatment, often with medication, by somebody like me in a reasonably quick way, they may then have an enormously long wait for the kind of talking therapy that may make a difference to their lives in the longer term. So we found, and again, this was pre-COVID, so this was at the end of 2019, that you can read yourself, obviously, but 1,500 people were waiting for longer than a year. And some were waiting for up to 2 years or even more. And I know that sadly in my local area, people can wait for up to 2 years for certain forms of psychotherapy, which, goodness, for people with stable lives and not much going on, is a very, very, very long time. For people who are in mental health crisis or who have regular crises, and people who have histories of, having had very traumatic and difficult experiences and who may move around significantly, what it really means is that actually the therapy is not available. The fascinating and probably the worst thing that we found was that these figures are a massive underestimate, because 9 in 10 CCGs, so clinical commissioning groups, the bodies that sort of fund and commission care in England and Wales at the moment, 90% of them keep no records of waiting times at all for the common kinds of therapy. So you could go to one of these organisations and ask them how long it is that people in the local area have to wait for a cataract operation or a hip operation or dentistry, and they would almost certainly be able to tell you exactly how many people were waiting and exactly what the average wait was. But in 90% of cases, they would have no idea about how many people and for how long were waiting for therapy. And I think that that kind of systemic problem was one of the most alarming things that we found. So things were not good pre-COVID. And then COVID came along. And we know that COVID has affected a number of groups of people more significantly than others. So we know that the elderly and people with comorbidities have endured really very, very prolonged isolation and inability to be with loved ones or to have simple daily contact at day centres or hairdressers or in the shops, and that now has been going on for some people for 16 months. And that's an awful long time. We know that people from some minority ethnic communities have been unduly affected both physically by COVID, with higher prevalence rates and higher death rates, tragically, but also economically by the effects of COVID and the withdrawal of some kinds of labour. We know that people living in poverty, often overlapping with the above two groups, have been more significantly affected than wealthier people. Interestingly, many wealthy people have become more wealthy during COVID. We know that vulnerable children who are out of school are a major source of concern and worry, because school for kids in those kind of situations isn't just about learning or about seeing friends or the social side of school. It's about safety and monitoring and surveillance. Teachers do an awful lot of that, which often goes unsaid and unrecognised. And obviously a lot of children have had the unfortunate experience of having exams cancelled or being on or off and not knowing where they are at a time that's difficult enough anyway. And we've seen soaring rates of particularly eating disorders in teenage and adolescent girls, with a doubling of referrals to specialist mental health services since COVID began. And we know that people with severe mental illness have been very adversely affected by COVID also, for a variety of reasons. One is, as mentioned above, their physical health tends to be less good and life expectancy is lower, so they are particularly vulnerable to the effects of COVID. And we were very grateful and supportive of them having been put in one of the higher priority groups for vaccination, regardless of age. But also services, many services had to close their doors and just work virtually, and that can be very difficult, particularly because many people with severe mental illnesses have digital poverty or very shaky access to internet access. One of the things that us psychiatrists are most worried about, though, is not necessarily COVID itself, but what is presumably certainly going to come next, which is a recession. And I'll explain a little bit about why that might be, none of which will be terribly surprising, I imagine. I like this picture by Banksy, which will apply to a lot of people, sadly. People doing A-levels, going to university or hoping to go to university and all that kind of stuff, or do apprenticeships or travel abroad on gap years. And sadly, we know that in this country, suicide has been the biggest killer of men under 50 for quite a long time now. And the next slide just shows some trends. Hopefully you can see my cursor. If you can't, someone please do shout out.
We can.
You can, excellent, thank you. So this is the Office of National Statistics suicide rates from obviously the early 1980s to 2 years ago. And these are the most up-to-date ones because it takes a little while to get all the data from coroners and other people. The top line is the rate in men. So this is rates, not numbers, per 100,000. So the light blue line at the top is men, and then women are substantially lower, as you can see. And the line in the middle is the average of those two, the overall rate of suicide per 100,000 of the population. And by international standards, this is relatively high, but by no means the highest rate of completed suicide. Probably an underestimate because of the information it relies on, but nevertheless, the way of collecting it has been relatively stable. And what you can see, I guess fairly clearly, is that over the 30 years or so, there has been a slow but steady and significant reduction in the suicide rate, with some blips. And these blips tend to come after recessions, particularly amongst men. And it's to do with joblessness, debt, and substance misuse, particularly. So mid-80s, late 90s, sort of mid to late 90s. 2007, you can see it was coming down nicely. And then there's a small blip around the time of the global financial crisis, which was fascinating because the suicide rate did rise there was a study of 24 high income group countries, I think in, Western Europe, the Far East and the US and Canada, which showed that the rate went up between 4 and 6%, which is sort of what this is. And then more worryingly, it started to creep up again before going down. But what you can see quite clearly is that in the absence of a recession, although with austerity ongoing, is that the rate, particularly in men, has been going up significantly. But the overall rate has been going up significantly as a result. And the big concern is that when these recessions came, the previous ones, they came after a period in which the rate was falling. Whereas what we're expecting is an increase in the suicide rate on top of a trend that we're already seeing for reasons that are uncertain. But almost certainly there is some effect from what I've been talking about with limited access to services for secondary prevention of suicide. So it's a very troubling picture potentially. In terms of numbers, what that equates to, it's around about 6,000 people a year who get to that point and successfully complete suicide, which is roughly one of these a week, depending on how tightly you pack people in. So a small jet once a week, hard to imagine really. But then if you take into account substance misuse in the UK, predominantly alcohol, you have to do pretty much the same again. And the two causes, for obvious reasons, I guess, which you don't need me to go into, are very, very closely related and often interlinked. So, going back to COVID and where we are, I wanted to talk a little bit about frontline workers. And by frontline workers, I think it's important that we think about the fact that it's not just NHS and social care staff, but many, many shop workers, funeral directors, police officers, firefighters, all these kind of people who had to be out interacting with people and putting themselves at risk are in a very similar boat. So we probably all know from experience that whatever branch of medicine we've been in, we've had some prolonged stress and uncertainty about what's going on, what may be coming along the line next, are things improving or not. Many of us have had changes in our working patterns, often at very short notice. I know trainees have been particularly affected, and general practitioners, with having to change ways of working, hours of working, and stepping in often at short notice for double rotas. And that can be very disruptive, particularly if there are people at home that need to be considered. And that's been another big worry. I don't know how people on the call have been on this one, but I know lots and lots of my colleagues and people I talk to, one of their biggest worries is about catching COVID, not necessarily for themselves, although not many people would want to have it, but it's about taking it home and giving it to people at home who may be more vulnerable. Worries about colleagues becoming ill, because most of us have quite friendly relationships with our colleagues and care about them and don't want them to be ill. I think particularly in acute healthcare and in primary care, I think witnessing so many people with infections, sadly many of whom had a poor outcome, has been very damaging. And the concept of moral injury is one that has been talked about increasingly over recent months. And we'll come back to that in a second. I just wanted to very briefly show this chart, which is the weekly death rate in the UK. And you can see that we've had about 10 weeks where the death rate has been over 5,000 a week. So that's about 700 people a day. So 10 weeks of really intense stress and pressure through the NHS, and another probably 10 or 15 weeks of very substantial pressure. And in these peaks is where the question of moral injury comes in. So this is a description of moral injury, which is a term that originally was used in the military where, you know, people who are not, just to put it very crudely, people who are not bad people being asked to do bad things, such as harm other people for the good of their country or for the good of others. And the distress and the feelings of guilt and the feelings of the post-traumatic symptoms that can cause, which we see so often in the military and in people who were in the military. And there's increasing discussion that people such as NHS workers, probably in this instance, particularly doctors, having to make decisions that they didn't sign up to have to make, particularly in such a wealthy country. The idea of rationing healthcare and making decisions that someone who potentially could benefit from a high-end treatment, such as ventilation, can't have it because there are other people and the pressures are too great. And they're not decisions really that many doctors were expecting to have to make during their careers. Plenty of other difficult decisions and life and death decisions, but not one that relates to resources and the rationing of care. And we do know that during those two big peaks, there were instances of this. So, the good news is we know quite clearly from other situations and from what we're seeing so far in NHS and social care staff that the majority of staff are going to be okay and not need any specific help. Some staff, and I think the estimates are about 1 in 10, actually have thrived on the busyness, the acuity, the need to act. It has validated them, and they have felt that they have achieved things in the last year that they possibly wouldn't have achieved. The majority of us do not fall into that group, and we've got by and we will be okay. But we think, so the government's own predictions are that between 10 and 20% of staff will require some form of specific input for mental health problems, whether that be therapy, medication, or some other kind of intervention. And that's a lot of people. So the NHS employs about 1.5 million staff. And the social care sector employs very roughly about the same. So 20% of 3 million is a lot of people needing help by the system that we've just been talking about, that's not really managing to provide the care that's needed already. Many more NHS staff and social care staff and members of the general population will have reduced well-being, which is a word that we hear an awful lot at the moment, isn't it? And one of the crucial distinctions for us at the BMA is this: it is crucial to have a distinction between reduced well-being, which is not illness, and people who are becoming ill because of COVID and the effects, or for any reason, because the responses are different. The response to reduced well-being we will talk about is predominantly around, for NHS staff, is predominantly around the workplace, ways of working, and offering a supportive environment and place where people can reflect and get support. The response to illness is treatment, as well as those other things. And it's a crucial that, and our fear is that decisions are being made based on people's well-being, not on the crucial group who are becoming ill and are at risk. And those illnesses so far are, that's probably about in the right order. So depression and anxiety, probably substance misuse as well, are more common than post-traumatic stress disorder per se, despite the traumas, because they're much more common conditions overall. So we're seeing lots of frontline staff presenting with those common mental health conditions and needing help. So the Department of Health and NHS England have, to be fair to them, opened some NHS wellbeing hubs. Everybody should have one in their region, and it's probably worth finding out where that is for yourself and colleagues in case it's needed. It's unclear how they've been funded in terms of whether the funding is new money or whether they're supposed to be being funded from mental health services already. And the scale is not enormous. So they're essentially like a very small community mental health team. And each sort of region has one. And so it varies a little bit, but each block of population of probably about 1 to 1.5 million people has them. So one concern is that they may well be swallowed up if the demand is as big as people think. But many third sector services are now offering support and help with wellbeing, and the BMA is doing quite a lot in that regard, which we'll come back to afterwards, which might again be a useful reference for yourself and colleagues. So coming back to NHS staff, and I guess this particularly probably applies to NHS staff who are working in secondary care for large organisations, because we know that it's very difficult for GP practices to provide some of these things because of issues of scale and setup. But they're not irrelevant in primary care, far from it. So what can employers do? They can provide things called employee assistance programs, which is rather an Americanized term, but essentially it's a system that allows for enhancements for staff, everything from discounted leisure equipment and bikes and gym membership to free counselling and all that kind of stuff. And there's good evidence that they do improve staff wellbeing and staff engagement and reduce turnover. Mentoring is something that has repeatedly come up in surveys and in discussions at the BMA amongst doctors, that one of the things that people feel would have been most helpful, or was most helpful if they had it, was the tradition in medicine of mentorship of new doctors and young doctors by senior colleagues, and also the working within teams that are discrete and relatively small, where people look out for each other. And much of that, with changes in healthcare, particularly in acute hospitals, much of that has unfortunately been lost. And what we hope and think is that the importance of that and the usefulness of that is something that people have been reminded of, and that moving forwards things might be different. Many hospitals and GP practices have removed rest areas for reasons of efficiency of space. But we know that it's important for people to be able to have a coffee and a chat and simple things, simple human interactions in a space where there aren't families or patients or in corridors. We know that flexibility is a key, and that there are many people during COVID who've managed to work extremely effectively, either largely from home or, for most of us, using a hybrid approach where we work from home and then are present in clinical areas when we're needed. I'm very conscious that that's not the case for all doctors, of course. And there are some staff who have had to be physically present continuously. But it's going to save money for the NHS if some people do work from home. It's environmentally more sustainable. And it probably will allow for a better quality of life for a lot of people. The importance of sensitivity and humanity around changes in where people work and changes in on-call rotas has been reinforced, and many people have had very significant changes but have managed and have coped and have been well supported by their organisations, and things have gone well. At the same time, sadly, there have been organisations where these kind of things have been a bit like a car crash, and there has been enormous bad feeling and some distress amongst staff as a result. But with sensitivity and humanity, things can be done well. And one thing we've done relatively recently is we've released a wellbeing charter for doctors that trusts are signing up to, and that we will be over the next few years holding them to account for how they're meeting these kind of targets, the things mentioned above. The crucial thing that employers need to do, of course, going back to what I said a few minutes ago, is to have very clear pathways for people who are becoming ill. So, you know, if you are a doctor in A&E at an acute trust and you are becoming depressed, how can you get care quickly? Because it's better for you, but it's also much better for the NHS and your trust. And therefore it's much better for patients if you can have time off, get better without having to wait a long time for treatment and come back to work and be able to provide care for others. So it's a no-brainer, really. So we know from, not from what I've said, but I've outlined above some of the reasons why the system for mental health care is too complex and too stretched. And we know that we need very clear pathways for frontline workers who become ill, either because of or just during COVID, because we need to keep the workforce as well as possible to meet the challenges which are coming up. We know there are 5 million people, for example, waiting for so-called routine surgery. Some progress has been made with these wellbeing hubs, but they are variable because there is local autonomy, which is a positive thing, but there is significant variability between them. And there's a real risk that they may be overwhelmed quite quickly. So there has been some talk about whether we need something similar to the military covenant. I don't know whether people are aware, but there is there's a covenant with members of the armed forces that if they need healthcare having left the armed forces, and this includes physical healthcare and mental healthcare, that they are given a choice of either remaining on a standard NHS waiting list or being given some level of priority. And that's something that's very highly valued by members of the military and something which seems to be the right thing to do, taking into account the principle of reciprocity. You know, people from the armed forces have done things and experienced things that they probably didn't want to for the greater good. And therefore we give them something back by promising them that we will look after them in a timely way if they need it as a result of those experiences. It doesn't work as well as it should do, but it does work quite well. And there's been a lot of talk that people will probably have noticed as to whether there should be something similar for NHS staff in particular and possibly social care staff as well. It's a very complicated issue, which I have very mixed feelings about. I think the principle of reciprocity, I think, should apply to healthcare staff for how they've stepped up and, you know, helped people get through this crisis. However, the armed forces, I think, have something like 100,000 members, and the NHS has 1.5 million members. So an NHS covenant would significantly warp the ability of non-NHS staff to get healthcare of any type. And that would be an enormous consideration and something that many people would feel very uncomfortable with. So there are some things happening. So this is, sorry, my screenshots aren't very good. I'm a bit of a technophobe, I have to confess. What we've been doing at the BMA over recent times is developing some policies and documents that we hope we can use to support doctors, particularly as individuals and in their organisations, but also to encourage and put pressure on where it's needed about how the National Health Service can look after its staff, including doctors, but also help the health service get back on track. And the most important one of those is called Rest, Recover and Restore. And I think those 3 words probably say it all. And it makes a number of recommendations, but the second group of recommendations are about mental health care, mental well-being. So, you know, all healthcare workers must be allowed to take leave as and when they need it, and employers must allow staff to carry over unused leave. And just in case you don't know, you do have a legal entitlement to carry over any annual leave from 2020 to 2021 to 2021 to 2022, up to 20 days. We think it's really important that for people who need it, so essentially for people who have families overseas, which obviously may include some people on this call, that there should be significant flexibility to allow people to go and see families and have more prolonged annual leave if they need it to quarantine at either end. And we're very clear that we need to be working hard with the National Health Service and with the new NHS People Plan, that a safe working environment is provided. And when we say safe, we mean safe in terms of COVID, but safe in terms of people's mental health and mental well-being. So a non-coercive, supportive, manageable environment with manageable workload levels. So this is a slide which is just a screenshot from the British Medical Association website. And if you Google BMA wellbeing, you will come to this. And there are lots of useful things which I thought it was worth just mentioning very briefly. So the BMA now has free and confidential 24/7 counselling services, which are open to all doctors and all medical students, plus their families, so partners and children, regardless of whether they're BMA members. So that's a really good number. If you've got people you're worried about or medical students you're worried about, then that's a very good thing to pass on and to have in mind for them. There's also a link to other sources of support, and there's now a psychotherapy service for any doctors, which unfortunately you do have to pay for, but it's heavily subsidised by the BMA and the Royal Medical Benevolent Fund. And a lot of doctors find that very helpful, because it can be difficult for us for various reasons to access our healthcare and to feel comfortable, particularly talking about things psychological and psychiatric with other professionals. So I think the fact that there is a service that's particularly aimed at doctors is confidential is really helpful. And then the final one, obviously, should people need it, is if people are having issues with the General Medical Council, there is support, because it's incredibly stressful. So just a few things that are available at the moment with the BMA, but there are lots more if you want to have a look. The other report, which has just come out, is less about staff and more about the wider impacts of COVID-19. And again, there were 10 points, and 3 of those are about mental health care. Unfortunately, they're numbers 8, 9, and 10, but you can't win them all. And we're asking the government to restore funding for public mental health to the levels that it was 6 years ago. I personally regarded that as a very sad objective, really, that we're asking for something to be returned to what it was 6 years ago rather than being increased. But such has been the situation that there is almost no public mental health care in this country, or public mental health promotion in this country. And it's clear that we're going to have to do a lot more in that regard. Our big and long-term ask regarding mental health services to allow them to meet the needs of the community, but also to meet the needs of frontline staff, is that funding for mental health services needs to match, give or take, the amount of healthcare that is mental health care, so 25%. So our formal policy is that over the period of the long-term plan, which is 10 years, that funding increases from the 12 to 13% that it is now to 25%, so that it essentially doubles across primary and secondary care. And also, crucially, we need to find out what the effects of COVID are on the mental health and the well-being of society, and what effect that is going to have on people presenting for specialist healthcare, so that we can develop the services needed to look after them. And we were talking about that a little bit at the beginning, and we've all seen huge changes, but we don't quite know what they are yet. And on that note, I'll finish. And thank you very much for listening to me.
Thank you very much, Andrew. It's a fascinating lectures, and I'm so sure there's plenty of questions that our members would have for you. Just before we move on to questions, I'd just like to remind everybody that we will be issuing certificates. So again, a few people already put the contact details in the chat below, but if you would like a certificate, receive a certificate of attendance, please pop your name and email address in the chat, and we'll be sending the certificates later on next week. So now we can move to questions, and perhaps I have so many, but perhaps I will start with one. Andrew, you mentioned that the public mental health in the country is pretty much absent. And I think me personally as a GP, I see a lot of people who can't present to us because of that, because they don't have anybody who exists in public space who would be talking about. I mean, social media do take over to a degree, but they basically suffer from a lack of public mental health. So my question to you would be this. The way I see it is that what happened in COVID is COVID accelerated a process that was already going on. It was the erosion of the sense-making structures within the society, whether that was the government, whether that was the church, or even the medical establishment, let's call it traditional medical establishment. A lot of this authority that these institutions had, and a lot of this authority in the sense-making area that people could use to kind of make sense. People were trusting these institutions to make sense of what was going on around. That was eroded. And so do you have any views on that? And do you think that sort of us as primary care, as medics, we kind of asked to take over what we are seeing in terms of the mental health, and then people presenting to us with eroded mental well-being or either medical illnesses? Is that sort of a fallout from the sense-making, collapse of the sense-making? Whether even medicine is the right institutions to take over from them. I don't know whether you had any views on that.
There's a lot in there and very interesting, and I couldn't agree more with it. I think COVID has accelerated many things, hasn't it? And it's held a mirror up to us and our societies. I think you're absolutely right that there does seem to be a lack in the society in terms of in government and in local communities of leadership and support for people and for society. And so much of what's called leadership or influence comes via social media or via the internet, which is very different. Some of it is wonderful regarding mental health care. Some of it is unbelievably toxic and unhelpful. But I think you're right. I mean, for me, one of the things that's been most heartening over recent months is the way that directors of public health in local areas have come to the fore after sort of the debacle with the national test and trace system, and how local areas have been setting up the structures that are needed and the networks that are needed again, many of those networks having withered, as you say, over recent decades, to provide that kind of support and that kind of healthcare. And I have a hope that if those networks survive, that we can use them and build on them to do things like mental health promotion and mental health self-care, and sort of provide support within communities that isn't medical, because many of these people who are in distress and in crisis are not unwell. So they need support and they need help and they need someone to talk to, but many of them don't need someone like me or a general practitioner, to give them tablets and things. It's not about that. It's about being disconnected and distressed.
Yeah, thank you. Okay, so if anyone else has a question, then please unmute yourself or raise a hand.
Yes, I have a question, if that's possible. A couple of comments and a question from a paediatrician. So thank you very much for a very interesting and talk that encompassed so many things. But I have a few observations on this. I mean, certainly on the lack of facilities, and I think COVID brought with it the fact that certain subspecialties which were less affected, i.e. pediatrics, for example, gave up some of their floor space really to try and cope with the whole mass of adult cases that were flowing in. Gave up our trainees to help with adult PICU, etc. And now that services are beginning to flow back, this floor space, which was supposed to be temporary, is certainly formed a permanent thing, and which has led to fragmentation of pediatric services. Our outpatients have been taken over for adult services. We've been put into different corners of the hospital. The whole pediatric unit has been fragmented, and therefore we are beginning to feel as pediatricians that this is sort of, well, it's led to a detriment in the pediatric care that we can give, because it's no longer a holistic approach for the child and family for the best interest of the child. So that's one sequelae that maybe many people don't talk about.
No, it's very troubling.
It is very troubling. And I think, it's like hitting your head against a brick wall. I think the adult physicians do not understand that a lot of pediatric disease has its roots in a lot of adult disease has its roots in pediatric well-being or lack of well-being, and therefore lots of epigenetic factors that are going to be kicked into play now will have its consequences down the line. I think the issue about CAMS and the lack of facilities and the lack of inpatient child and adolescent psychiatry beds has predated COVID. And we were pre-COVID even babysitting adolescents with severe psychiatric symptoms on the pediatric ward, waiting for days for beds. And we were not in the correct place and not having the right specialists to be able to manage these children. So the situation is even more acute as we speak, even with more children presenting or adolescents presenting with, for example, eating disorders, as you mentioned. But I think on top of that, there is a real problem with what PIMS TS is doing, because we're now very overloaded with all the extra new children coming in with infections, and be it RSV, be it influenza, be it now more PIMS TS coming in as a third, beginning to come in as another wave. And the neurocognitive issues that we find, I mean, some of these children will end up with MRI abnormalities. And what are the long-term sequelae for this? This will have a big impact on their, well, presumably psychiatric symptoms, but we don't know as yet. And all the generations of, all the whole generation of children that have missed out on their neurodevelopment, be it through social isolation, be it through lack of schooling, and this will have an impact on another generation. So I think, I don't know what your views are on the PIMS TS thing and the whole impact that this will have for generations of future people who have missed out on their neurodevelopment.
Goodness, yeah. I mean, firstly, going back to your first point about the space in paediatrics, I don't know whether you want to take this offline and get in touch with me directly, but that is certainly something that I would want to, and be very happy to challenge through the BMA Consultants Committee, because obviously that I'm a member of that, and although I'm a psychiatrist, there are many paediatricians and people from different specialties, obviously, and that is the kind of issue that we would very much like to support colleagues with if it's happening, which it sounds like it is. So please do get in touch with me if you want. In terms of children's services, yes, I mean, it's hard to know where to start, really, in terms of the enormous demand amongst young children and school children, and government policy has evolved, and some funding has been made available for vulnerable children in schools to have access to support and counselling. The difficulty, or one of the difficulties, is that is finding the people who are really unwell or at real risk of becoming very unwell amongst a huge mass of people, of young people who are distressed and who need a very different approach. The numbers of people who are being flagged up as being of concern are so enormous that it's difficult to even go through them and triage properly and find the people that desperately need help. And I agree with you. I think we're just sadly storing up problems for later on. One of the big problems, sadly, with changing things, though, is staffing, and that we know that even if, you know, the Department of Health were to say, here's loads more money for mental health services, we wouldn't really be able to change much at the moment, because we have a chronic shortage of doctors, we have a chronic shortage of mental health nurses and social workers. So change is going to take many, many years. But you're right. I'm sorry I've not answered your question, but it really is very troubling.
Yeah. I mean, it would be really interesting to know what the exact effect of PIMS would be on the neurocognitive development of people, and what is the prevalence of this? We won't know until we continue monitoring. And I don't think big swathes of people are going to be monitored to see what actually goes on. Mm. Thank you.
Thank you.
All right. Thank you very much. Are there any more questions? Maybe in the meantime, I'll have another question. So, Andrew, you mentioned that you've been working with NHS Trust on things like mental health charter or mental well-being charter from the VNA side. As a primary care physician, I notice a lack of such approach in vast majority of primary care practices. I mean, all you have to do is look at the jobs being advertised. None of them mention any of the employees' assistance programs. And very often we consult people who work in institutions, financial institutions or other institutions around London, especially young people who have things like access to gym, access to psychological help, which is paid for by their employers. Is BMA working with primary care on improving that? Because personally, I think that this is something that's lacking.
Yeah, you're absolutely right. I mean, I guess so. In terms of the BMA, so the BMA is very primary care focused because our chair of council and the deputy chair of council are both practicing general practitioners. So they're, and a huge part of our membership are GPs. So there is a very strong focus on GPs, which is great. But you're right, there is a real issue with how do practices, which are basically small businesses in sort of one form or another, how can they provide these kind of things? And it's a massive problem. So I'm meeting with the minister responsible on Tuesday, the new health secretary, not them, because interestingly, it's the Minister for Social Care who's responsible for NHS staff wellbeing. And one of the things that we're going to be discussing on Tuesday is, yes, how do we get these kind of offerings for staff in primary care? Obviously, I'll be saying doctors, but it means everybody. And what can be done about that? Whether there can be some kind of, I don't know, whether there would be a national system or a way that trusts GP practices can sort of come together to, have a shared service in a region. I don't know, but it's something that, will be in the discussion, definitely.
Thank you very much, Andrew. Okay, does anyone else have a question?
Sorry.
Sorry, please go. Yeah.
There was one question in the chat from Martina, and there was one hand raised as well. Sorry.
Oh, right. Sorry. I'll just have a look in the chat. Sorry. Yes, Martina. Good question. So for non-English speakers. And it's a big issue where I work as well, actually, in South Oxfordshire, because I often get disappointed patients because they see an appointment with me. And unfortunately, I can't speak any Polish at all, which is embarrassing, but just one of those things. And we have a very large Polish community where I work, and I see several people, and we use interpreters. There aren't that many specific Polish mental health services that I'm aware of. I don't know whether other people on the call are. What it is very worth people knowing, though, is that mainstream services have a responsibility or a duty to provide care in the individual's language. So, for example, when I see my patients who don't speak good English, or in one or two cases, we use an interpreter, and there are no issues about that. So the advice, I think it might be different in the bigger cities like Manchester, Birmingham and London, and I'm sorry, I don't know exactly what's available there, but I suspect there might be some specific Polish language mental health services, but certainly in, smaller conurbations, it's probably going to your local NHS services, but for people to be very clear that, or to be very aware that they are to interpretation.
If I may add to it, I had few patients who were using private psychology services in Poland via Zoom.
Yeah.
That's how to get around it. I see there is.
I have quite a few patients who have Skype therapy with Polish therapists. And actually, it's funny because normally we worry about that kind of thing, but it works really well.
There's one hand raised, a gentleman sitting in a car in a blue jacket.
Yes. Christoph Kilan, regards from Hull.
Hello.
I'm, I would like to say digital psychiatrist, 30 years in artificial intelligence technology. I had passion in Poland as a coordinator of international European grants. I moved to England, and last year I decided that I didn't finish my mission, what should be introduction of artificial intelligence technology to psychiatry. And technically speaking, very soon I would like to approach Synergy Grant European. I sent you, private chat as well about it. And second bit is about the monitoring and assessment of depressive episodes, because this is first time when we use fuzzy logic technology, because symptoms of depression are fuzzy, not 0-1. And you can assess with precision. And the problem from primary care I can see, because now it's integration of primary care with secondary care, is GP will ask me when my competency finish, when I should refer patients to different, speciality. And we have got in psychiatry two types of settings. One is community psychiatry and one is acute settings. And to be honest with you, the scenario change in terms of, intensity, that intensity of this depression is, in 4 levels, not three levels, like is described in research diagnostic criteria. Therefore, there is some money coming. Therefore, I've seen, innovation in terms of, in local area, and generally, we can access this money presumably, because this is the point. And in terms of, our local settings connected to, help from Polish psychiatrists, this kind of area, I think we have got a lot of, native speaker, in Polish, and hopefully in Hull or in Grimsby, it will be possible to seek help in, native language. Thank you very much.
Thank you. And I've just seen your message. I don't have your email address, but if you want to email me, then do. But you're right. I mean, tell him, using virtual technologies. I mean, the one real positive of COVID has been that it's accelerated that, hasn't it, and made it clear how useful it is.
Yeah,
for most people, not for everybody, but for most people.
Yeah, because I'm thinking about the tool, because we cannot replace doctor, but it will be very useful tool, from computer and app. When you can assess, severity in 4 levels, and can advise when the patient should be treated. And the same role is for care co involved, which means community, and obviously this app will be for family and others. In terms of Synergy Grant, it will be much ambitious approach, because we can use video technology for face analysis. And technically speaking, you can see effect coming from your face. Therefore, you will have as well automatic recognition that there's something wrong with you. Okay?
Goodness.
As a technophobe, that's something that's that might be a bit scary for you, Andrew.
Yeah, scary but fascinating.
Thank you very much. Eva, I don't know whether you had a question or not, because you unmuted yourself. Do you have any other question for Andrew?
Well, no, I was just wondering about the new ICSs that will be coming in, and how will psychiatry and CAMS in particular, for my liking, how is that all going to fit in the future?
Goodness. Yes. So do people know what about ICS? So ICS stands for Integrated Care System, which is based on an American model of healthcare, where the system in a region would then be, in America, will then be, run by a company. So Kaiser Permanente is probably the most famous one, but there are others. In this country, that's not going to be how it works. Obviously, one worry is that it does open up that possibility that a sort of a regional health system, in theory, could probably come under a company. That's not the plan, and it seems pretty inconceivable at the moment, but it's not impossible. So it seems that what's been recreated almost are regional health authorities. And if there are other people who are old enough, like I am, to remember them, they were essentially that, authority got devolved to a region, which was usually, they varied, 1 million to a couple of million people for all physical and mental health care. And decisions were made at that level, which is very much how it's going to be with ICSs. How's it going to work out? I don't know. My worry is that it could go either way. It could perpetuate the problem at the moment, which is that mental health services, in terms of getting money, will usually come second to acute trusts because of the way that the two types of healthcare are funded. It does give an opportunity for that to change. I think it's going to depend a lot on the voice of mental health services in those systems. And it's going to be really important that they have a strong voice to advocate for mental health services to get a bigger share, probably, or at least the share they get at the moment of the funding to be able to provide services. So I think there's definitely a risk with ICSs, but also an opportunity.
Thank you. I think that as far as I understand, and I may be wrong because I'm not involved in those discussions, is that there are acute and community services are being represented there, but very little from the educational, because I'm also sit in the educational field as well. And therefore, if you're looking at provision of future doctors, nurses, multidisciplinary teams and training, that's not figuring very highly in current discussions, which I'm a bit worried about, that this may take a back seat and it'll only be provision of frontline services that will be provided, and education will be an afterthought, and therefore less training, less doctors, less psychologists, less other staff being available in the long run, or poorer training. Difficult to say.
I can see that, and that with commissioning and with a lot of mental health services going into sort of the private sector or the voluntary sector, training is one of the things that has suffered enormously, and because they tend to be focused, like you say, predominantly on service provision. But that's why it's going to be keeping people like me busy, I guess, holding ICSs to account about things like that, and all of us.
Thanks, yeah.
Thank you very much. Are there any more questions?
Yes, I have one comment. I became aware, touching up on the previous discussion about access to practitioners speaking particular language, I was made aware that there is something like right to choose in the NHS, and it has been mainly used in the ADHD services, where there is a great shortage of NHS services, doctors and practitioners. And apparently the patient can choose to see a private ADHD specialist, and then that would be funded through NHS. I was wondering that in the same vein, this could be used for doctors or psychotherapists speaking particular language and being aware of particular culture. And again, with the internet technology, that would be quite accessible to patient, but I'm not aware about how it works in practice in terms of funding. I don't know whether anyone else is aware.
it's not my area of expertise, I'm afraid. I do know that people have a right to choose, and I've heard about the ADHD services. I think people have to be very wary, because I think a lot of trusts will be very resistant to it for obvious reasons, I guess. So I don't know, I'm afraid. I don't know whether anyone else on the call knows anything.
I guess that's a no. All right, would anyone else have a question, or are we ready to wrap up the meeting? Okay, I think we're done with questions. Andrew, thank you very much. It was a fascinating lecture. I will contact you privately if you don't mind, because I'm interested in whether I can contribute to what BMA is doing in doctors' wellbeing space, and I'll be happy to contribute if I could. So thank you very much for this amazing lecture. Bożena, would you like to add a few words?
Andrew, thank you very much for this really fascinating lecture, and I'm sure it affects all of us, whatever our specialties, and even us retired practitioners, but really it affects everyone, and it's a very, very interesting subject. So thank you ever so much for joining us today, and hopefully we will be able to meet up in the Sikorski Institute in the future. We will keep you posted on all our meetings, the next one being the 26th of September, with a lunch afterwards at the Ognisko Club and the Polish Hearth. So I'd like to say, really thank you very, very much. This was a wonderful morning. And to everyone else on the call, great to have you with us, and hopefully see you all on the 26th of September. Dziękuję i do widzenia.
Dziękuję bardzo.
Dziękuję, do widzenia.
Do widzenia.
Dziękuję, do widzenia. Do widzenia. Thank you very much once again.
Thank you.
Andrew, you as a host, you're like the captain of the ship now. You have to be the last one to go. No, feel free to close it. I'll not be.
No. But thank you very much for inviting